Good afternoon, everyone, my dear colleagues. So welcome to the section Normal Tension Glaucoma. I'm Dr. Ningli Wang from Beijing Tongren Hospital. Also, I'm the president of the Chinese Glaucoma Society. I'm lovely to have this section with our audience and our speakers. Today, we will have 4 speakers. We will give the 4 talks on the normal tension glaucoma. Normal tension glaucoma is a very special type of the open-angle glaucoma. The percentage of the normal tension glaucoma among the primary open-angle glaucoma is quite different between the nations and the countries and the regions. East Asia and China is a high prevalent regions of the normal tension glaucoma. Recently, we have one population-based study discovered the percentage of the normal tension glaucoma among the open-angle glaucoma is come to the 83%. And also, our groups, our teams, and Allingham's teams discovered the normal tension glaucoma usually have lower intracranial pressures. Lower intracranial pressures maybe is one of the risk factors. And also, from the traditional Chinese medicine's aspect and some clinical studies, we discovered the normal tension glaucoma is very strongly related to the systemic abnormalities, just like the Flamm syndromes and some lower BMI and microcirculation and so on. And also, we invited one doctor from the northern part of the China. Her team is working on the genetics aspect on the normal tension glaucoma. So finally, I hope the speakers will bring us the new information and let's have interactions between the audience and the speakers to make up our knowledge about the normal tension glaucoma and to get the new information. Really enjoying everyone joining us. Thank you. Good afternoon, my colleagues and dear friends. Today, I was invited to give a talk on the normal tension glaucoma and the Flamm syndromes. I'm Dr. Ningli Wang from Beijing Tongren Eye Center. Actually, for my talk, I will focus on the Flamm syndromes and from some view of the traditional Chinese medicine. So here is my commercial interest. There is no commercial interest to declare. So the normal tension glaucoma also, the prevalence is quite high in China. The percentage of the normal tension glaucoma among the open-angle glaucoma in China, it comes to the 83%. And compared with the nations, the different regions, we found Asia, especially East Asia, have a high prevalence of the normal tension glaucoma. So, for the normal tension glaucoma, some studies discovered besides the intraocular pressures, even the translaminar cribosas pressures difference between the ocular and the intracranial pressures, and there is some kind of contributions from the blood circulations, ischemia, from the microcirculation. So from the literatures, there is some studies focus on the one kind of syndromes. We got some more and more literatures refer to the glaucoma, normal tension glaucoma, strongly related to some systemic abnormalities just like most of the patients have some migraines. The most of the normal tension glaucoma usually suffer from the migraines and phlegm syndromes. So, however, when we got the data to do the data analysis, we found their difference was not distinct among the Asia patients. What is the reason? So we follow the diagnosis criteria from the Western countries. There is normal tension glaucoma, maybe it's over diagnosed in the Asia country, and that can cause not a very distinct categories of the normal tension glaucoma and high pressure glaucoma. That may be the reason contributed to the over recent studies. So far, we did not find the different distributions of phlegm syndromes between the normal tension glaucoma and the high pressure open angle glaucoma. For the normal tension glaucoma, the phlegm syndromes was diagnosed by the comprehensive elevations, and we in the some clinic, in the some hospitals, we use near-field capillary scope that can give us the overhands, extremes, the microcirculations situations. And also for the fundus is another windows to see the microcirculations. So from our team, we did the one studies to do the comparison study to see the near-field microcirculation, if this circulation is related to the have a stronger correlations with the retina's microcirculation. From our studies, we found that for the two system of the microcirculations, there is a strong correlations. And if the patient suffer from the phlegm syndromes, the patient will have the near-field microcirculations changes, and also meanwhile the patients will have some kind of defect on the retina's microcirculation. So this paper already published on the journal in the health subjects, near-field capillary ludicentis and abnormalities are also associated with reduction of the retina nerve fiber layers thickness and retina's vascular density. So here shows the technique we used for the microcirculations to see the hands, extremes, the microcirculations. Now let's back to see what the traditional Chinese medicine to think about the glaucoma, especially the normal tension glaucoma. For the normal tension glaucoma, in the histories of the traditional Chinese medicine's books, they are described this kind of disease as a five winds cataract or bluish glaucoma. And from the traditional Chinese medicines, the eye always considered is part of our bodies, not the independent, separated organs. From the point of the view of the traditional Chinese medicine, our individuals can be divided into the 9 subtypes of the constitution. So follows this kind of category of the constitution of the glaucoma, we found the different types of the glaucoma have the different constitutions tendency. So for the higher pressures glaucoma, they usually have the different constitutions tendency. For the normal tangent glaucoma, they usually tend to have Qi deficiency or Yang deficiency constitution. This means this kind of distributions of the Qi deficiency and Yang deficiency exactly look like the Flem's syndromes. So from the Western medicine and the traditional Chinese medicines, both of them give us the evidence. The normal tangent glaucoma strongly relate to the systemic abnormalities, especially microcirculations. So for the normal tangent glaucoma, really is one kind of complicated open-angle glaucoma. Maybe it is a term of the umbrella. Under the umbrella, there is a different risk factors for the normal tangent glaucoma, just like the increased translaminar curve has pressure difference, and the genes mutations, and microcirculation. So we need some new discoveries to get the new knowledges about the normal tangent glaucoma to look for efficient treatment strategies for the normal tangent glaucoma. Thank you again for my teams, for my colleagues, for the contributions to the normal tangent glaucoma studies. Thank you.
I'm Jun Chen from INENT Hospital of Fudan University, Shanghai, China. And my topic today is how to differentiate autosomal dominant optic atrophy and young normal tangent glaucoma. I have no conflicts of interest to declare. Normal tangent glaucoma is a type of primary open-angle glaucoma, characterizing by glaucomatous disc changes, progressive INFL thickening, typically visual field defects, open anterior chamber angles, and constantly the LP less than 21 millimeters of mercury. Autosomal dominant optic atrophy, that's ADOA, is one of the most common type of hereditary optic neuropsis. ADOA typically represents as insidious, progressive, and symmetric vision loss, temporal or diffuse optic disc failure, color vision deficits, and central or pericentral visual field defects. As both characterized by losing of retinal ganglion cells or the axons, ADOA and NTG have many overlapping clinical manifestations and are often misdiagnosed in clinic. The main point to distinguish ADOA from NTG include early onset ages, central vision loss with sparing of the peripheral field, and family history. However, some ADOA patients may occur vision loss in adults, while NTG patients may be diagnosed in young individuals. The disc excavation of optic nerve is a typical feature of normal tangent glaucoma, but can also be observed in ADOA patients. So more differential features between ADOA and NTG should be investigated. In this study, we performed a clinical investigation, especially the OCT examination on 25 Chinese ADOA patients and 21 Chinese normal tangent glaucoma patients to compare the difference between two groups. We recruited 25 unrelated patients with ADOA and 21 unrelated patients with NTG. Patients with ADOA were included in our study when meeting the following criteria: the gradual bilateral vision loss, bilateral optic disc failure on fundus examination, and the most important is that the identification of OPA1 or OPA3 mutations. The inclusion criteria for NTG patients in our study was as following: the glaucomatous optic disc damage or glaucomatous visual field defects. The anterior chamber angle is open. The IOP is less than 21 millimeters of mercury. And the age of the patient's diagnosis is less than 30 years old. All the patients underwent a complete ophthalmic examination. The NFL analysis, ganglion cell complex analysis, and optic nerve head analysis was performed using SD-OCT. And the NFL thickness, GCC thickness, and CD ratios parameters were calculated by the system building software. As for the genetic analysis of ADOA patients, the whole blood samples of patients with ADOA and their available relatives were collected for genomic DNA extraction. And the genetic test was performed in 25 patients by next generation sequencing NGS. And all detected variants were verified by Sanger sequencing. Here is the demographic and the clinical features of two groups. Although we enrolled young patients with NTG, the onset age of ADOA groups is still significantly younger than that of the NTG group. Most of ADOA patients present to our clinics with poor visual acuity and complain of vision loss, while most of our NTG patients visited our clinic because of suspicions of glaucomatous optic nerve damage, which were detected in regular health examination. There was no significant difference in sex distribution and IOP between two groups. 9 ADOA patients had family history of poor vision. We used the OCT to access the papillary NFL thickness, ganglion cell complex thickness, and CD ratio, which could present the rules of RGC cells and the axons. And a significant reduction of RFL thickness in the temporal lower and the nasal lower sector was found in ADOA patients comparing to NTG patients, while the RFL thickness of other sectors and the average RFL thickness, there was of no significant difference between two groups. The optic nerve head analysis reveals that the CD ratio was significantly larger in NTG groups than in ADOA group. All ADOA patients underwent genetic analysis by NGS. In total, 25 OPA1 pathogenic variants were found in the 24 patients, and 1 pathogenic variant in OPA3 were identified in 1 patient. All patients carried heterozygous mutations, except 1 patient carried confounded heterozygous mutations in OPA1. Among 25 detected OPA1 mutations, 48% variants were deletion and nonsense, which induce a premature translate termination and result in capital insufficiency. 36% were missense mutations and 16% were splicing mutations. These variants might be harmful to the OPA1 transcription and translation, and ultimately damage the function of mitochondria. Here is the conclusion. The RFL thickness of the temporal row sector and the nasal row sector and the reduction of GCC thickness are more severe in ODOA patients than in normal tension glaucoma patients. Because of the overlapping clinical features, genetic testing and completed ophthalmic examination should be performed in patients suspected ODOA or young patients suspected of normal tension glaucoma. Thank you very much for your attention.
Good day, ladies and gentlemen. I'm Zhang Shiqi, member of Professor Yuan's team from 2nd Affiliated Hospital of Harbin Medical University. It's a great honor to attend the Congress. Today, we are going to talk about the mechanism and the treatment of optin E50K associated abnormal tension glaucoma. E50K mutation of optinonurin lead to serious clinical symptoms and hard to therapy. The mechanism remains unclear, and our result had indicated that E50K change the expression of neurotrophic factors and resulting in RGC dyes. And young bone marrow SCAL1 positive stem cells could be as a key factor to enhance tissue repair and regeneration to rescue retinal of E50K. So our team have focused on this topic for years, and today I'd like to give a presentation on recent findings of our research. Thank you. Hello, everyone. It's my great honor to make the presentation about mechanism of optin E50K induced apoptosis of RGCs and the protection of young bone marrow SCAL1 cells. First, thanks for the National Natural Science Foundation support since 2005, and there are no conflict of interest. As our study showed that up to 92% of patients with POAG are the types of normal tension glaucoma, and there are about 21% NTG patients have a family history of glaucoma, which indicated that genetics may play an important role in this pathogenesis. And in 2008, we found a mutation in optin gene from a NTG family in the northern China. The optin gene encodes the protein optinurin, which is important in several cellular functions, and it was identified in 2002, and there are many mutations that have been found in the glaucoma families. Among all the mutations, E50K specifically lead to the apoptosis of RGCs, but the reason is not clear. So to investigate the mechanism of E50K-induced RGC dyes, we made a E50K point mutant mice model by CRISPR-Cas9 technology, and we compare the differences between wild-type and E50K mice. The point mutant mice present a normal intraocular pressure, and there are no differences in the anterior chamber. However, the E50K mice present stay longer time in light box, and also the mutation decreases their number of optomotor response, which means they have a worse visual function. At the same time, the flash VP showed E50K mice have a lower P2 amplitude, and it gave us further evidence. Then the tissue section examination showed that E50K mice have a thinner retina, and also then we labeled the RGC by neuron staining, and we found that the E50K mice have a less RGC numbers. So there's the question, why does optin E50K cause these changes? We further studied the positive underlying mechanism. The results showed that E50K impairs the autophagy flux in retina, and also it leads to TDP43 abnormally increased in cytoplasmic and decreased in neuroclear. It was associated with the abnormal autophagy flux, and it also influenced the function of TDP43 about interaction with Desser and Joshua. Moreover, the abnormal TDP43 decreased the expression of microRNA, which is very important in BDNF regulatory regulation will characterize the pathway. And we know BDNF is an important neurotrophic factor in retinal survival. And also, our proteomic analysis reveals that neurotrophic signaling pathway is one of the enriched pathway. So we detected several neurotrophic factors expression, and they are all lower in T50K mice. This suggested that neurotrophic factors may be used for treatment. But the problem is that the neurotrophic factors stay a short time in vivo because they are easily degraded. And more importantly, their therapeutic effect for RGC is poor. So the natural question is that what is the better way to repair the RGC dyes caused by E50K? During the last 10 years, bone marrow stem cells have been widely investigated, and these outcomes suggest that these cells could be endogenous neuroprotective factors in treating retinal neuropathies. And numerous studies show that bone marrow derived cells could be homed to repair injuries tissue, and young bone marrow stem cells have had a stronger power to regeneration. Now the question still remains that which type of bone marrow stem cells have more power? The SCAR1 has been widely used as a marker to isolate stem cells, and the cells expressing early ocular markers were also highly enriched in the bone marrow SCAR1 positive population. Recently, our group found that the specific type of bone marrow cells, SCAR1 positive, were important contributors to rescue and recover visual function in the retinal after glaucoma injury. So we tried to investigate whether wild-type young bone marrow SCAR1 stem cells could be as a key factor to rescue retina of E50K. In this figure, we can see that 4 types of neurotrophic factors all have a higher expression level in young SCAR1 positive cells. Then the E50K retinal explants were co-cultured with the young bone marrow SCAR1 positive or negative from cells from wild type and E50K mice. And after co-culture, the SCAR1 positive cells increased neurotrophic factor expression in E50K retina, and it also reduced the apoptosis of RGCs. And we can see that there are less terminal positive cells after co-culture with SCAR1 positive cells. So to further test the efficacy of stem cell therapy, we made a bone marrow chimeric mouse model. And after stem cell therapy, the SCAR1 positive cells significantly improve the visual function of E50K mice. And also, it improved the retinal thickness. All important, we can see that there are more SCAR1 positive cells home to the retina, and they also decrease the apoptosis of RGCs in vivo. And further results suggest that the upregulated neurotrophic function expression were involved in this improvement. So in summary, we found that opting E50K leads to RGC dyes by various mechanisms, and stem cells therapy offer new possibilities for the treatment of RGC apoptosis induced by E50K. And in the end, I'd like to thank all our members for their contribution. And I also thank you for your attention. Thanks.
It's a great honor to be invited to the next World Glaucoma Congress. I'm Dr. Yang Fan Yang from Zhongshan Ophthalmic Center, Sanyas University in China. Today, the topic of my presentation is the baseline intraocular pressure and diurnal fluctuation of open-angle glaucoma and ocular hypertension from the light China trial. Light China trial is laser in glaucoma and ocular hypertension trial. It's a RCT to evaluate whether selective laser trabeculoplasty as a first-line treatment provides superior economy and health-related quality of life outcomes to medical treatment of patients with open-angle glaucoma and ocular hypertension in China. Today, I'm going to focus on the baseline IOP characteristics in its diurnal fluctuation in the light China cohort. Briefly speaking, patients with newly diagnosed untreated PLAG in one or both eyes or OHT qualifying from treatment according to NICE guidelines were enrolled. Those who have contradiction to SLT or those who are unable to randomization or have some visually significant cataracts and others ophthalmic conditions were excluded. Finally, 622 PLAG patients and 149 OHT patients were recruited at Zhongshan Ophthalmic Center from March 2015 to January 2018. Subjects was randomized to SLT first or medicine first treatment. As for the IOP measurement, GAT was used in the daytime phasing, and Zeus tonometer was used to obtain nocturnal IOP. Daytime phasing IOP was recorded at 5 times intervals during the day. 24 hours phasing IOP was recorded at extra 5 times in the nighttime. In our study, we used four terms to describe IOP fluctuation, that is P-IOP, throat IOP, IOP fluctuation, and MAPE. MAPE map is a recently proposed definitions to describe the fluctuation of intraocular pressure. Next, I will introduce the results of our study. This is the baseline characteristics of 771 subjects in the light China trial. 1,105 PLAG eyes and 271 OHT eyes was enrolled in the trial. As is shown in the chart, mean IOP was 20.23 for eyes diagnosis with OAG and 24.44 for OHT eyes. OHT eyes has higher IOP and thicker cystity than PLAG eyes. To further find out the risk factors of higher IOP, correlation and regression analysis was conducted. As you can see in the results of the multiple regression analysis, in both groups, younger age, male gender, and thicker cystity was associated with higher IOP of OAG patients, while only thicker cystity is related to the higher IOP of OHT patients. As for the IOP fluctuation, of the 1,376 eyes identified, 948 PLAG eyes and 264 OHT eyes accepted daytime phasing IOP measurements, while 24 hours phasing IOP was obtained from 70 eyes. Here is the daytime fluctuation of IOP shown in the chart. The majority of eyes had their P-IOP recorded at 8 o'clock, and the lowest IOP values mostly occur at 14:30 in both diagnostic groups. As for the curve, the higher IOP occurs at 8 o'clock and graduates degrade during the day to reach its lowest value in 14:30. Next, let's move the 24 hours results. This is the phasing curve, indicated mean IOP loss from 10 p.m. and shows an obvious peak between 5 a.m. and 7 a.m. in both POAG and OHG eyes. Besides, nocturnal IOP was higher than daytime IOP in both groups. More than 80% POAG eyes and OHG eyes had their peak IOP outside clinic hours. Here is a comparison chart showing the IOP fluctuation data in the daytime and 24-hour spacing. According to the results, here is a brief summary about the IOP fluctuation in the light channel cohort. First, OHG eyes shows larger IOP fluctuation than POAG eyes in either the daytime or the 24-hour spacing curve. Second, OHG eyes had higher level of MAPE than POAG eyes in the daytime spacing, but shows no significant difference with POAG eyes in the 24-hour spacing. Third, 24-hour spacing shows higher IOP fluctuation and MAPE than daytime spacing in both groups. That is all of my presentation. Thank you for your attention. We are open to discussion and contact us by the email below.